Just, yeah, it's all in confidence. Go for it.
Oh my God, we've had some horrendously awkward patients, 2 of them, who are you just can't speak to. Proper bullying type people.
Really?
Yeah, one guy who owns many businesses, has hundreds and hundreds of staff, and another guy who's obviously done very well for himself in his life, and he's over 70, and they treat the staff horrendously. We've had to sack one from the practice, and he's threatening to take it legal because he doesn't like it. Oh dear Lord.
Interesting. And how do you manage them in terms of, I guess they want to be seen if they're but they want the level of service, but they want to be able to speak. Excellent. Cool. Being recorded.
Okay, we could talk after.
But it all kind of got resolved and so on. I guess that the patient wants to be seen still.
Well, one was a referral, so we've just said no.
Okay, fair enough.
The other one, yeah, I mean, we will do, but there is no rhyme or reason, or there's no he should not be rude to the staff. There's no reason for them to be rude to people.
Was he rude to you though, Wail?
Never. They never are, don't they? They always.
No, this is it. So you hear all of this, but you're the doctor, or however they see you, and you've got the sharp, pointy instrument or whatever, and you're they never are.
It's awful. So
this is your kind of your relaxation away from all of that, just talking about what we do and what you do and so on. So I guess this is a bit away from all of that.
My friend, I'm ready to get properly slated because and I'll apologize to you now because there's some, I was supposed to be very biased towards implants. So there's the perio bit that says, oh, this is,
I won't name names, but there is quite an eminent dentist that once told me that how he manages perio in central London is to take the teeth out and place implants. So I've seen all sorts of things, and I'm here to kind of hear what you have to say and maybe add a bit of balance to things as well. So
that would be nice. I've got a bit of balance right at the end, just so they all don't.
Okay, yeah.
I'm completely insane, but I'll tell them my history so they know I'm not an implantologist, but a properly trained dentist.
Fair enough. Well, it's gone on past 7:30, so we can actually formally kind of crack on. Do you want to share? Do you want to pop your video on and share screen?
There you go. And what do I do? Share screen?
Yeah, so you can share your presentation there as well.
Share. Where are you? There. Share.
Excellent.
I've got this little thing in the middle of it that says the host has asked you to start your video. Shall I do that?
I think that you have. So I think we can see what we need to now as well.
Start my video. Okay, done.
So yeah, we're good to go. So Wail is going to be. I'll give a brief introduction, and then I'll let you get on with your proper introduction. But Wail has a long history with us, preceding my time at Gentle Dental Care, and I'll let him go into that, and possibly why Dad is on the screen as well as Avi and so on. So I'll let him discuss that. But the bottom line is that he runs a very successful practice in Oxfordshire, and it's a referral practice. And some of my colleagues are actually working with him. People that I went to the Eastman with as well, Paneet and Asad and co. I presume they're still there, are they?
Yeah, absolutely.
Excellent. So no, that's good. And a referral practice, very successful, well thought of, and an excellent educator. I think I had Grant McCary. He was talking about how he was influenced at some stage by your teachings there as well. So it's great, and I can see your practice in the background there as well. So
that is it. Yeah, Grant's a wonderful chap. Actually, Grant McCary, I've known him for 15 years or so. Wonderful bloke.
Yeah, he was amazing. He was speaking so highly of you when we last spoke as well. Excellent. Well, the floor is yours. It's titanium versus teeth.
Thank you. And please do interrupt when you wish if there are any pertinent questions, because this was supposed to be a lecture we were supposed to give in real life before the whole COVID crisis. So a year ago, I was supposed to be down your way, my hometown, really, to give this lecture. And this lecture really is supposed to be one for audience participation, because it is, as you would probably have guessed, quite a highly biased lecture towards implants. But we'll get into that in a minute. I firstly just wanted to thank you, Mish, of course, and National Dental Seminars, and Avi, and of course, Kamlesh, who had a massive, talking about influence, a massive influence in my life. My VT trainer, the first practice I ever worked in, and I've got to say, I'm extremely lucky and very fortunate to have gone to that practice. It was a twist of fate that he very much took me on, and it was, he taught me how to be a dentist, and not only that, but how to be a proper person, how to deal with people. So, I can't thank him enough, and it's a massive honor to be asked to speak for you guys. So thank you very much. Right, getting on with it. Titanium or teeth. Basically, this is supposed to be a highly biased view for why we should actually move on from teeth and place implants. So I came out of dental school thinking I could save everything. And before anyone starts groaning, that's the only animation I'm going to have in this lecture. But you come in thinking, right, I'm a hero, I can save everything. And as time goes on, I think, well, maybe not. Should I be saving everything, or is there a better solution? But before we get into that, I just thought I'd give you a little bit of background. So I qualified from King's in London and went into VT, like I said, with Kamlesh at Gentle Dental Care in Thornton Heath. Then I left there, great foundation, actually. Went to St. George's in a couple of years at MaxFax. And then very lucky to have got into the Eastman Dental Institute. At the time, it was a 2-year full-term degree in conservative dentistry. Before Dents came about, or before implant courses came about, we just did everything together in one course. That was brilliant training for me. And then I was incredibly lucky to have been asked to join the most amazing practice I know, which was Devonshire House in Cambridge. I know you said we're a referral practice, but actually we have our own patients. We're a general practice full of specialists of every speciality. And we've got some fantastic people working for us. A lot of the slides that are coming up, the clinical cases, are ours. We like to view ourselves as Devonshire House, not individual dentists, which is why we're quite a tight group. So a lot of the cases are mine, my colleagues, and thanks to them for allowing me to show them. So the aims for today, really, we're going to talk about teeth versus implants, when to sacrifice, understand the decision making, how to provide implants, how we do it, why, the long-term predictability of them. Should we save teeth, or really just take the long-term view and say, is it worth it? Are we wasting people's money? And the cost effectiveness of it. And ultimately, really, are we doing the right thing? I think that's one question that we're always going to ask ourselves with any sort of treatment that we do. So I just thought I'd start off by the general premise of the ultimate goal of restorative dentistry is preservation of the teeth and surrounding structures. Now, this was a quote by Devan in, 52? And I thought about this. I'm thinking, well, at the time, what were the options? They didn't really have any other options. So that was the goal, because didn't have anything better. Do we have that now? We'll see at the end of this lecture, I think. But one thing is true, as we all know, that every time we touch a tooth with anything, with a drill, the restoration gets bigger. That's been proven. And ultimately, we call it the restorative spiral. So what we really want, as Stephen Chen very kindly said in the ITI consensus in 2016, was that we want sustainable dental health one way or another. Now, I put this picture up. I hope you can all see very clearly. Now, to me, that's health. It's beautiful health, beautiful dentition. But actually, one of those is an implant. And we're going to go back to this case later on. And you can decide whether we were insane or whether we did the right thing. So I put this slide up because I thought, well, going back to that implant, it's the value of what we have in our mouths. And this typifies a lot of our patients, I think. Before they have something, they value it massively. When they actually have it, implant restoration, full arch bridges, whatever, they tend to think, oh, well, it's there. They lose the value in it. And then the recalls start being missed, and the care isn't quite as there unless they're properly well educated. But then after they lose it, suddenly the value of something goes up again. I thought that was really pertinent to what we do on a daily basis. So just basically going over osseointegration, I'm sure you all know that it's a process where the rigid fixation of an alloplastic material is achieved, and with long-term functional loading. So what do we know about modern dental implants? Well, we know they're different, but what the obvious differences are, there's no PDL. So we don't get that feedback. There's no proprioception. There's reduced blood supply to the area. So that repair process that a tooth might undergo doesn't with an implant. And it reduced capacity for axial displacement. Does that mean we shouldn't use them? Or do we just not understand it properly? And therefore we see failures, not because of the implant themselves, but because of what we do with them. And the most important thing is that the prostheses, the implants, they're replacements. They're not regeneration of tooth tissue. I find a lot of people view them as, it's my new tooth. Well, it's not. You've lost your tooth. That's gone, and gone for good. But we're replacing it with something. So is it the same sort of care? Should you value it more? It's one of those constant arguments I have with trying to convince patients that there has to be a change in terms of care, because whatever we put in will fail otherwise. So why dental implants? I'll just give you a few examples of why we use them nowadays. Tooth preservation, as in not touching the adjacent teeth. I've got some studies to show you why implants are better than various bridges and any type of other restoration. It's a fixed option. People like fixed teeth, especially nowadays. They don't want anything removable. Certainly where we are, they don't expect to come in and have a removable prosthesis. They want something fixed all the time. It's predictable. We have cumulative survival rates of over 90s. They support and retain a removable partial denture. Again, it's still removable, but it's more fixed. People are functional with that. Orthodontic anchorage, these are very kindly donated by our orthodontist, Professor Dirk Bister, showing us what he can do with implants, actual proper implants, not the stainless steel screws that are placed between the teeth, but one in the palate to help fixation, get rid of headgear. Or do we go for the ultimate tooth replacement, where we go for the next stage, full arch, immediate loading? And we have a couple of cases that we've done where we put 6 implants, tuberosity implants, pterygoid implants. We've had full arch cases above, and it changes people's lives. And today, we still get people coming in saying, I'd like my teeth removed and implants placed. And I know this lecture is all about, saying absolutely, that's the better option, but you've really got to think about that. And is that the right thing? Because it just worries me when people come in and ask for things like that. So just going quickly over space requirements. When doing anything, we know that we need to do it properly. For example, a porcelain fused to metal crown, we need the proper metal support for the porcelain design features. With implants, we need the space for the bone between the teeth, depending on the size of the implant. So we need a good 1.5 millimeters, or really 2 millimeters between teeth and implants, and the type of space that we have in terms of occlusal space, minimum 5 millimeters. And this picture shows here where the measurements are. One of my favorite teeth, this premolar, which we'll get into in a minute. I'm sure you've seen a lot of these premolars with big fillings in. So criteria for success of osseointegrated implants. We want it immobile, of course. We don't want any peri-implant radiolucency on the radiograph, and vertical bones. We don't really want any bone loss, measurable bone loss year on year. We want it stable, much like this Brannemark type 4 external hex implant, which has been there for multiple years. But it just so happens that I was referred a case just a couple of days ago, which I thought I'd put up, which is this. It's a new Nobel active implant, which quite clearly shows around the coronal end a bit of bone loss. And if you have a look about 2-3 millimeters up from the apex, there's a little bit of radiolucency around those threads as well. That's not a great sight. And we think, something wrong is going on there, I think. But generally, when done right, implant success rate is over the 90s. This is in the mandible from by Lenkholm in 99, over 90% success rate over 15 years. So it's been widely accepted. It's been a proven treatment modality. We have various types of endosseous implants for single to full arch cases. And again, study after study shows that the survival rate is over 90. And we really got to think about that. If it's that successful, then why are we actually bothering to do anything else in terms of this heroic type dentistry with posts and cores and huge cores? Many a time we see crowns come back in people's hands and not in their mouths. And I just think we've got to think about what restoration we're doing to a person for their teeth and whether it's worthwhile in the long term. It's all about prognosis and longevity. And this is the type of result we actually want to get every single time, really. Papillae, natural looking, keratinized mucosa, and bone stability. So Peterson in 2012 said the systemic review of survival and complication after a mean of 40 is 72% after 5 years. So again, it's getting higher and higher. But when you take out the older implants, which were the machined ones, and just have the roughened implants, which is what we generally tend to use nowadays, it's near the 100%. Yeah, I don't think you can get any better than that, really. It's one of the most successful treatment modalities in dentistry, I can argue. And Priest in 1999 also said that using implants avoids the use of the other teeth, adjacent teeth. So single restorations with implants prevents treatment or bridge preparation or any preparation to the adjacent teeth. So there's a role in doing that. But looking at conventional tooth-supported bridges, we have to look at their success rates as well. Now, I've come from a purely conservative background where we did a lot of crown and bridge work. And a lot of the teeth I was putting bridges on to span gaps were heavily restored. That was one of the criteria. If it was restored and it had an MOD or a filling of any sort, then we would say, yeah, I'd restore it. I'll prep it as we normally would. Whereas if it wasn't restored in any way, there was an argument not to and use something else, a Maryland type acid etch retained bridge. So it's already compromised with a huge filling. And then we're going to add more trauma to it by giving a person a fixed prosthesis retained on the adjacent teeth. So you have to think about the aspect of, should we be doing that? Why affect or treat the other teeth when we have a perfectly good and successful treatment modality in our drawers? Just because also you might not be versed or trained in implant treatment doesn't necessarily mean you shouldn't offer it. There's always people around that can. You just have to align yourself with someone or a practice that does this sort of thing and to be supported by them. So survival of conventional tooth-supported bridges falls to about 65% at 20 years. Now, 20 years is quite good, I bet, but these are, well-maintained dentitions studied over a long period. However, when it does fail, it does tend to fail catastrophically. And this slide on the left-hand side with the decoronation of that abutment, you've got to think, well, what effect does it have on the distal abutment as well? Because that is now a massive cantilever. And will that affect it? So you could end up losing the whole arch of teeth because of one going. You also have to think about the longevity and success rates, really. A good friend of mine, John Good, did his MSc project on this in 96, on how long a crown lasts. And he had hundreds of crowns that he looked at on various materials. And these were all done by specialists in hospital. And he found that with specialist care, it was 12 to 17 years. Now, we've all had that question. How long does it last? How long am I expecting my crowns to last? We'll get into that a little bit later on, but that's what John's study showed. I personally don't say 12 to 17 years, but we'll get into that a little bit later. For bridge abutments as well, we have various papers saying, like the Goodacre and Spilnick paper, almost a third of the bridge abutments go non-vital in 5 years. That's just too short for me. And when they do go non-vital, what happens? We do a root treatment. So on this slide, with an angled tooth, tilted tooth, and an angled corrected crown on top, it's going to take a very, very special endodontist to get the canal first time and not reduce the internal coronal tissue massively to undermine that crown. So we've got to think about the consequences of treatment and the consequences of planning treatment as well. Should we be doing these bridges or not? And how far do we go to save teeth? You know, we've all seen cracks in teeth. We've all seen the extent of the cracks and the bone loss and the continued pain that people have, and the quality of life that they have because of the pain. Then we look at the amount of dentine, and then we're looking at feral effect. How much dentine do we need? Because we're getting closer and closer to the root. Will this crown last? And I say, should we be doing that? Or when we have a perfectly healthy and successful alternative, should we just be saying, well, you know, it's fractured, it's unlikely to be useful unless we spend thousands of pounds and time on something whose prognosis isn't that good? Should we just be removing the teeth and placing implants directly? So I have my dilemma, the premolar dilemma. I'm sure all of you have seen pictures like this, or in your own practices, where you have heavily filled, all premolars nowadays seem to be restored with an MOD amalgam or more. And it just shows to me that, you know, they do crack, they fracture. So my favorite tooth is the upper first premolar. It has two thin, spindly roots, a canine fossa, a medial groove. And if there was ever a tooth that says to me, I'm going to fracture, that's the one. And you can see on this middle picture, the contact points with the opposing teeth. It's the way they contact, it puts too much pressure on the cusps. They are designed to break. So what are we looking at with cost benefit for implants? Now, this study, the clinical effectiveness of implant-supported single tooth replacement, a young person seeking replacement of a single missing tooth with traditional fixed prosthodontics, forget implants, they say that they require 2 to 3 replacements during their lifetime. And I think that's good, 2 to 3 replacements. I think it's a lot more in reality, to be honest with you. But every time you do, like I said earlier, you ruin more and more of the teeth and the supporting structures. And it's just a spiral. It's just this restorative spiral to the end point, which is, funnily enough, implants, because you end up losing the tooth. So implants are more expensive. Yes, they are. There's a higher training involved with them. There's a higher risk factor, of course. There's surgery involved. The actual componentry and the materials and equipment that goes with it is more expensive. So therefore they are. However, a JP Morgan study in 2008 showed that there is a break-even point estimated to be around 7 years. And obviously we want everything to last a little bit longer than that. But in terms of the cost of a crown or restoration or an implant, the break-even point is 7 years, taking everything into consideration. Now, like this lecture, this slide is from Noble Biocare, so it's highly biased from their point of view. But again, it says a similar sort of thing, and they've taken the information from the JP Morgan study, which shows that single implant shows 30% cost savings over 20 years for over a fixed prosthesis. But not only that, I would add that if the fixed 3-unit bridge fixed prosthesis does fail, it takes the teeth with it, at least one. So I think that we've got to think about the cost effectiveness of long-term treatment for the patient. And what this doesn't take into account is if the bridge does fail, are we looking at replacing all the teeth with implants or just the 2? There's issues there that we can get into. So we're going to get into some cases in a minute, just so we can see whether we've done the right thing or not. But really, we're faced with a challenge. Every day we're faced with this multidisciplinary treatment planning question. Do we save the tooth or do we not? Do we restore and do we base this on what? On biology, structure, function, aesthetics, value, cost? What are we basing on the patient's views, or maybe us? Maybe because I don't do much endo anymore, I won't necessarily look at it. You know, we shouldn't be basing our decisions on the fact that we're not good at something. We need to take an overall sound view. However, is there a role for periodontics anymore? Why should we be pushing the limits of what our materials and teeth can cope with when we have dental implants? So I'm going to show you a couple of cases. This is normally part of the lecture where I ask people to put their hands up and say, would you do this, would you not? But for the sake of the Zoom meeting and COVID as it is, I'm just going to go through it and tell you how we went through the decision. So we're going to look at a traumatized upper central incisor, what decision time we make. Now this person, obviously young, in their 20s, look at the gingivae, type 1 type 1 gingivae with a very thin biotype, thin papillae. It's just, you worry about this sort of case. Smile line, I would say, is high because that's not a full smile, and they've had this trauma. And this is when we normally have a show of hands of who would take this out and do an implant, who would restore it. What would you do? How would you treat this complicated fracture? What should we consider? What are the consequences of the treatment as well? Well, we took an X-ray. This is what was inside. We had what I would say quite a poor root treatment, tight area in that site with the roots quite close. We can just about make out the incisor foramen, but how much tooth structure have we got, and what's the trauma to the teeth? So should we take it out? You know, this is, I'd love to see how many people would say yes and how many people say no. Well, I'm not crazy. We didn't take it out, of course. Didn't jump on the implant wagon straight away. We did a root treatment. We did it properly in my 90s conservative dentistry way, conserve the tooth structure. And you sort of feel pretty good about it because you think, well, we're going to give this person a little bit more time with this tooth. So we did a root treatment, but a specialist endodontist, looks fantastic. Did the composites, build up. Now, this is the time when we consider root canal treatment success rates and whether we did the right thing. Now, strict criteria by Paula NG. I was incredibly lucky to be training when Paula NG was working at that Eastman. She's absolutely fantastic, extremely knowledgeable, and a very, very talented endodontist. Now, with her paper, strict criteria, primary root canal treatment, not great, I would say. We're in the 70s and 80s compared to what I would call success rates for implants. But secondary root canal treatment, which this effectively was, that case effectively was, is in the 70s. Now, you might think I'm crazy because 70s is still excellent, really, in terms of success rate. If someone said to me, you had a 70% chance of winning the lottery, that's fantastic. So why am I looking at it in a purely negative way? Well, this is why. They had recurrent apical infections. The person, even though we did all this work and spent all that money, their quality of life wasn't fantastic because it was continuous. There was an issue there. 1 year later, it never really settled. There was a current apical infection. What were the causes? We didn't really know. Was it root fractures, extra canals? And what the options? Do we give antibiotics? Well, we just don't do that anymore. We don't give antibiotics to cure our problems in a chronic way and hope the patient gets better. We know there's something wrong. So do we re-root treatment, a third root treatment, and what will that do to success rates? Or do we XLA, we remove the tooth, and do we put a bridge there or we put implants? If you remember, let's just go back, what the patient had, to pretty much virgin teeth either side and beautiful teeth. So a conventional bridge is completely out of the question. A Maryland bridge, is that great for this? Look at the occlusion. Have we got space? It's a reconstruction waiting to happen, really. So what do we do? Well, you know what I did, I think, by the terms of this lecture, placed an implant straight away and immediate. Now, all these cases are decades old. We're talking 10 years plus. And things, the way we do things at the moment have changed. There's partial extraction therapy where people keeping the buccal aspect of the socket. There's different types of grafting, soft tissue grafting. There's soft tissue materials that we can use. But we just did the immediate implants and placed a provisional crown on it. And I've got to say that looks, to me, pretty acceptable. Provisional crown is a little bit short, of course, because we want to just make sure the occlusion is protected. Obviously give a mouth guard, protect it straight away. And then we do the customized impression coping, because we work the gingiva, and then have a definitive restoration, which I think is incredibly good. Lovely lab work by Richard Giddon at the time. And I think the result for me is excellent, because the papillae is still there as well in this, what I would call a high smile line. And then I think, well, this patient, lovely person, has spent a lot of money in 1 year for something that didn't work. And we did it in good faith, of course, but should I have just gone straight away? Should we have just placed an implant straight away? And I think, well, maybe in this case we should have. The next case, a failing upper central incisor. I'm putting central incisors up because, as you all well know, it's the hardest tooth to get right in terms of appearance. So these are the scary cases that come in, which we don't like. Same sort of thing. We have a post that's going off pieced. We have an area on it. It's obviously failing. We have a diastema. If you have just keep an eye on that diastema, keep that in your mind. So what do? I mean, in the 80s, we'd have probably removed that post. Heroics, we'd have done heroics. We removed the post, spent 2 sessions at the Eastman removing that post, repair the post canal, we re-root treat it. Then we look for root fractures to make sure that there's none there. And then we assess the coronal dentine. But we worry about bone loss, so we worry about drifting of teeth, we worry about all this sort of thing. So what would we do in this sort of situation? Well, exactly what we did in this situation. Straight away put an implant in there, because weighing up the costs and the success rates of what we had there and getting it right, that it was just too risky to remove that post and not fracture the tooth. So I didn't think it was worth the risk. And we placed an implant. We're not affiliated with any specific implant company, so you'll see lots of implants of different makes here. So we're not sponsored by anyone, and you can just about make out on the adjacent teeth, we've got little backings on there. So we had space issues. We had customized healing abutments with a temporary prosthesis and middle Maryland that we had on there. And we had that issue with the diastema that we showed you on the first slide on the x-ray, which the patient didn't want anymore. Now, the customized healing abutment was wonderful because it helped at the time. This was like 10 years ago. That's what they had from Straumann. That helped us maintain the papillae, which is all important, because too many cases, I grew up in a time where we took out teeth, let it heal for 6 months. So everything resorbed and shrunk away and the papillae disappeared. Then you put an implant in and everyone's left with food traps. But now it's gone full circle. We're trying to preserve everything. So temporary in place with a little composite on the right lateral to try and build up to see what it looked like. But then we think, actually, we can do better than that, because it's not a great result. It's acceptable as a temporary, but not great. And who here makes their temporaries perfect first time? So we did the double diagnostic wax up to show the patient what it looks like, because talking to people, we know clearly in our minds what we're talking about, but the patients need visual aids and they need to see what their teeth will look like in different ways. So you can see when you're showing a patient this, there's only one choice: symmetry every time. And which is what we've done. This was the slide we showed you right at the beginning of the lecture. So the implant crown, implant restoration, is the upper left central incisor. And what's lovely about it, it's maintained its papillae. And it just looks like, as Stephen Chen said in the ITI in 2016, natural dentition. That's what we want. And a little bit of composite on the side of the other one. So again, I think reasonably good result, I think. And that's what it looks like after, with bone stability. And we're reviewing all these patients. We're lucky enough, because we're not just a referral practice, we're lucky enough to see our patients every year or every 2 years on recalls, so we can monitor how we're doing with these cases. And yeah, there have been some failures, don't get me wrong. we're not perfect by any means. There's failures, but we also get to manage them and take care of them. So in this sort of situation, again, the implant survival rates, 93 to 97% for partial dentarism for single tooth replacement therapy, which has got to be brilliant. You've got to think that's the way to go, really. So endodontically treated teeth. Now we're getting on to why implants would be better than doing anything else. So the failures, 60% prosthetic reasons, periodontal reasons for endos like periendo lesions, 32%, 5 to 10 years, or pure endo reasons, 10% within 2 years. So there's a lot of failure with every other treatment modality. And we've all seen this, these dentator screw-in posts, they used to call them. I used to use them as well. I hold my hand up, you know, at the Eastman or in the 80s when I was doing various practice jobs. That's what we had. I didn't know any better, but it's all about feel, and they were great root fractures. And then things like this, where the root treatments are short. Could you do better? Could you not? I did this during, you know, treatment during my learning formative years. You do the best you can with the little knowledge that you had until you have a great mentor like Canal. She taught me how to do things properly. And this is what happens. Are we actually just waiting for teeth to break and suffer the consequences of those fractures, like bone loss, to prevent implants going in, or having a major problem with the amount of bone that we're left with? Or do we just say, do you know what, let's just get the tooth out while we've got the bone and put something that's more stable, has a better success rate and a longer longevity? There's an answer for it. Now, this is one of my cases, implants or bridge. Now we can see from that x-ray, we've got the two molars, the 26 and 27 upper left first and second molar, which have quite poor root treatments. Patient came to me. We ended up doing a full reconstruction on this patient, and we got to this quadrant and we thought, well, what do I do? They're heavily filled. Do I do the whole crown lengthening, try and get some more dentine, do a root treatment? There's areas there, there's conical roots. I just didn't think it was worth it personally. I just thought extract it as soon as possible and get healing and allow it to heal. We put crowns, we did the roots, we did the reconstruction on the other teeth, and I'm left with this. Now I'm getting to this stage and thinking, well, do we do a CBCT or should I put a bridge? We've got a healthy tooth at the back, even though that 8 is worn. So it's worn, it's lost tooth structure, so I could put a crown on it. It's going to have something anyway. So why not just place a bridge? Now I know the success and failure rates of bridges, and we look at the abutment teeth. One's a conical root, the other one, the 5, the second premolar, is a short rooted tooth, again conical, not massive. It's quite a long span. And what else do I have in my armamentarium? I think, well, you know, I do a lot of implants. Let's look at that. That's got to be better. So let's look at survival rates for bridges, which doesn't make for great reading, really. Again, like the abutments, 23%, a third of them require endo, and with that endo comes fracture and loss of coronal tooth structure. Whereas you've got the implant survival rates well into the 90s, nearly 100%. You just can't argue with that sort of thing. So I planned it. I just planned it for implants because I thought longevity-wise, I'll get better result with that, even though it's not a straightforward implant. We're looking at sinus lifting at the same time. This was done in, I think, 2008, 2009, that sort of area. So sinus lift was done a lateral window approach because we've got about 4 to 5 millimeters of bone. I'm I generally tend to try and place 10 millimeter implants into the sinus, prepare them, make sure the angles are correct, and I've got the length, and you can see on that slide, one goes up to 12 millimeters, one measuring gauge goes up to 10 millimeters. I've got enough space, I've lifted the sinus enough, and then place the implants. These are bone level implants, and I've placed autogenous bone and then xenograft, bios and bioguide on top, double layer, and then allow it to heal. just allowed to heal. And I know this was 2008, 2009, because this beautiful lab work was done again by Richard Giddon. And the reason why I know it's that because I haven't done a cement retained crown in about 10 to 12 years. And these were 2 cement retained crowns. Why? I have no idea, to be honest with you. I can't remember why I decided to put cement retained crowns on there, because they were perfectly screw retainable. But that is what I did, and I joined them. I connected them because they were in grafted tissue in a sinus. So I didn't trust things at the time. And this was a pre-cementation radiograph to make sure that everything fitted pretty good and good spacing. And they've been there. I review the patient every year. So they have been there from 2008, 2009 until this year. Actually, I saw the patient this year, and everything's stable. So everything is going the way I expect it to with regards to the survival rates and all the studies. So I'm happy. Then we have this upper case. Now this is quite interesting, an upper anterior segment. This is what we have. Clinical shot, so you can see the wear on the opposing teeth, the over-exaggerated curve of SPE. We have the upper anterior teeth with fractured posts, root treatments. We've got a bit of everything here. We've got the upper left central and lateral incisor with a great method of retaining a core and crown using Stabilock pins. This is what I think they were being sold at the time as fully automatic Stabilock pins that you could just shoot repeatedly into the teeth. But that takes proper skill. And it does actually take skill to get everything stable and functioning for many years. So we're left with this, and what do we do? Now, if this was the 80s, I'd be looking at doing crown lengthening to try and get more root, then a post and core on each one, and then a femoral effect of about 2 millimeters. Keep those canines, even though they have been prepped aggressively, I would say, and a little bit of caries palatally on the upper right canine. So the longevity of those is questionable. So this is another show hands situation. Who would remove 3 to 3? Who would remove the centrals, laterals, or who would do what? And again, it all comes down to longevity and what would we do and what we're going to give this patient. I don't know about you. I've certainly seen a change in the past 30 years of what people are prepared to put up with and what they want. And a lot of them nowadays want it now, and they want it perfect, and there's no compromise at all. So which teeth do we keep? Look at the preparations on those canines. That's a heavy prep. Do we have concerns? I have got concerns because they're my guiding teeth, those canines. So what do we do? And we've already seen the occlusal scheme on the over option of the lower anterior. So the canines, the anteriors, are going to take a lot of guidance, which is always an issue. But I'm firmly in the camp of protecting teeth and protecting restorations afterwards. They're just part of my treatment plans regarding giving a Michigan splint or a protective hard occlusal splint afterwards. So I saw this phrased from Nelson Mandela. I thought, absolutely, may your choices reflect your hopes and not your fears. I want to make proper choices, really, with what I hope to achieve. I don't want to make choices because I'm scared. That's the wrong way of doing dentistry. I don't want to be fearful of restoring. I don't want to fear failure. Things are going to fail. I have to just be happy with that and know that's going to happen, but not be the cause of that failure. I don't want to fear trying something else just because it might fail or I'm not good at it. You have to. And I have to make sure there's something to fall back on. So decided actually keep the canines, remove everything else, and place immediate implants and immediate load the bridge. So we've got a temporary bridge that's immediate loaded and then in function like that. And the reason for immediate loading and temporization long term is just to see how he functions and make sure that everything works, everything doesn't fall apart, decement, or screws loosening, because otherwise I don't want to know that that's going to happen with the final restorations. We need to know during temporization stage. So the evidence, survival evidence, the combined success rates after 6 years were 84% for endo, 95 for implants, and 81 for fixed and partial dentures. So we know who's the clear leader in this race, really. Now, this is another one of our patients, extremely poor attender. The other thing I should have put under poor attender was he's a barrister, or was a barrister at the time I was treating him. So that didn't scare me in any way, but this is how he came in. Now, poor attender, but if you look at the gingiva, things aren't great. He obviously doesn't really take care of his teeth brilliantly well, but it's stained. But there's not a lot of reddening, irritation, gingivitis. There's a little bit there, but it's surprising. This is his lateral views. So you can see he's got an anterior open bite. His only contacts were on the molars, both sides, and one was on the premolar. So he's got 2 contacts maintaining his whole jaw. That's a difficult situation to be in. And the jaw is just breaking apart, falling apart. The only teeth that are reasonable are his lower incisors, really. And this is his OPG, his DPT. And what do? Remember, he's a barrister. So does that cloud my judgment? It shouldn't do. He's still a person. A very well-spoken, pinstriped person with glasses, but he's a lovely man. And the other thing is that I ended up seeing him every other Saturday because his son played football in the same league that my son did. So we were on the opposite sides of the pitch every other Sunday. And if you want to do treatment, that's right. You need to be doing it on people that you're going to be seeing repeatedly. So there's no extra stress there in any way. So what do? Nowadays, honestly, hand on heart, I would probably be looking at a full clearance and immediate full arch loaded prosthesis. But is that right? Is that the right thing to do? I still have that debate now. And I think, yeah, probably it is, because what am I going to do with these teeth? There's caries everywhere. They're not great. Do I do a slow approach, or do I just get stuck in and go for it right from the beginning and get that final bit of treatment done? But I did the slow approach at the time. I put implants, got rid of everything, put implants in the lowers, root treated the uppers, composite everywhere, just as I was trained at Eastman. And then he disappeared, completely disappeared. 5 years, because he was stable. He didn't have back teeth on the uppers, but he was stable. He looked good. He was in court all the time, and he just disappeared for 5 years. I saw his wife, though. The kid stopped playing football at that age, which was thankful. Otherwise, I would have given him a look to make sure he returned. But then he came back, and this is how he came back. Sorry, this is how he came back. There was caries on the anterior teeth. There were areas, there was bone loss. And that's when we decided, right, enough's enough. The upper jaw has got to go. Clearance in the upper jaw. And that's what I decided to do. Clearance of the upper jaw and go for broke. But at that stage, I wanted to do bilateral sinus lifts to put more than an all-on four implants in a full immediate loaded bridge, because I thought with his occlusion, anterior open bite, there's going to be a lot of posterior loading. So I put in many more implants to stabilize. 1, 2, 3, 4, 5, 6, 7, 8 implants in the chap. This is my verification jig to make sure he's got the right occlusal vertical dimension, because we've got a lovely lower jaw that was restored. And then we went with an FP1, a fixed prosthesis 1, just replacing the teeth. And this is, again, beautiful lab work by Richard Giddon of Oral Design in London. He does some amazing work. And a hybrid type design where I've got some screw retained, some cement retained. This was done many, many, many years ago before angulated screw channel came in. So, which is why I've got a couple of implants that are cement retained. So this also shows how long he had to complete his treatment, because this was the original photograph with one camera, a Canon, and my upgraded camera. You can see different colorings. So before and after shots. Now we've managed to give him an overjet and an overbite. It's still a slight anterior open bite, but overall good result, I think. And maybe I should have just gone with this long term. I mean, he's been like this now for over 10 years, thank goodness, and been stable. That central incisor on the lower still annoys the hell out of me, because he just can't seem to manage to keep that clean, but everything else is. But again, I'm looking back, reflecting on this, thinking, why did I bother doing all of that restorative work when I should have just gone for implants? So when do we place implants? What's the time? Do we postpone placement of implants until 20 years old? I've had patients that need implants young, but we just don't do them. And I think, oh, is 25 years old okay? Well, it's not. There are changes in anterior face height through life. There's continuous alveolar development. I have a patient that I placed an implant at the Eastman in the 90s. I see him still now. So it's been one implant in upper central, and that's been there over 20 years. And he is now 60, placed it in his 40, and there's been over eruption of all the other teeth. There is a good millimetre and a half incisal edge discrepancy between the two. So there's continual movement throughout life. And patients have to be aware of that, really. It's still an exceptionally happy and surviving implant. But this one, again, was donated by a colleague. This is a great timeline showing both treatment modalities. A right central incisor was heavily compromised, but it had a post and core crown on it, root treatment, and the left had an implant. Both excellent treatment, like one of those old Corvent type implants, both brilliant. But then there are photographic evidence over the years showing that the incisal edges just slightly start to move. And 2012, it's just unacceptable anymore. So they were replaced. And that's both crowns are replaced. And this is how it looks. And you think, well, this is one of those fantastic anecdotal type evidence case reports where you think we've had an implant, we've had a post and core, which lasted longer. The decision is yours. Were they protected? Which is better? We have that gingival margin discrepancy. Should we have put 2 implants in there so they didn't move? It's one of those things. So survival of well-maintained teeth. Now this study shows, Axelson in 2004 in a Perio journal shows, there's an amazing study that the concept is that good maintenance provides good outcome. So there's a 6-year study which turned into a 30-year recall following 550 patients, followed about 370 of them in 2 groups. The first group, regular 3-month recall with supportive maintenance care. The control group were just left. And they found that, 375 patients were followed up over 30 years. And basically, it shows that preventive dentistry works well, as long as you have good recall and a good level of compliance. I have very few, hand on heart, very few patients that are that religious coming back. So what we have to think about is they may not. And if they don't, then what's going to happen to our restorations? Because everything's not perfect in life. So we've got to think about success rates when it comes to planning work. And we can't rely, with the best will in the world, we cannot rely on the patients taking care of their work unless they're educated and are that way inclined. And that's very few. Or do we take it into our hands and give them the best possible chance of success long term? So views on implants, our patients' views, they think, oh, it's a quick, easy treatment. They have no idea. Or is it major surgery that they're terrified of? It's going to be horrendous. They think it's cheap, which obviously it's not. And they think that once it's done, it's done. There's no care needed. I don't need my tooth. I haven't got my tooth. I've got my implant. Don't need to take care of it anymore. And they want it done immediately. They always think that the implant, when it's placed, is the tooth. It is not. And they never need replacing. And everything lasts forever, of course. Well, I've gone complete full circle. And I say, no, nothing ever lasts forever. And I ask them, I pose the question to them. And I say, what have you got that you have bought that has lasted forever? Name me one thing. So let's look at the factors affecting individual tooth prognosis. We're going to look at periodontal, endodontic, and restorative factors. So apologies to any periodontists in the audience. This, like I said, is highly biased view, but just quoting papers. It doesn't necessarily show my view on perio. But it's very difficult to accurately assess the prognosis of periodontally involved teeth. Maguire, this is quite harsh. Even I felt this was quite harsh. You know, projections are no more predictable than the toss of a coin. You know, I think that says more about the patients than the actual care of treatment and the quality and the expertise of the periodontist. Please, no hate mail. The greater variety and variability of survival rate for loss of teeth. You know, initial prognosis was good and the survival range of 4 months to 12 years. That's a massive amount of time between two, so anything could happen during the two. So OWA in Dental Update 2018, you know, what did they say? Prognosis is variable and unreliable for perio disease. It's unpredictable. Anteriors survive better than posteriors. Well, yeah, we can understand that. And canines with their big roots that are being used all the time, are least likely to be used, are lost. So the interesting thing is, on the lower study, Carusis in 2007, the survival rate of implants in patients with chronic perio is 90% at 10 years and 95% with patients without perio. I think there'll be a lot of argument about that, but you know, it's there. So the endodontic factors, we've talked about endo already, about the success rates for apical surgery is about 70%. But again, who's doing it? We've got to think about who's doing the apical surgery, and a lot of the endodontists are highly skilled and can show a lot of success rate. But then we've got to think about, it's still not as good as putting an implant in there, really. Restorative factors as well. You know, a root treated tooth, we all know what happens with that, and the dentine that you go through causing the trauma for endodontic access. And you've got to think about how long is that going to last. So the difficulty is to combine all those factors, all those decisions in one decision of what to do. Should we be doing it? You know, the endodontically treated teeth is the weakest link. So do we actually use it, or do we go in a more pragmatic way, more predictable way? That's our challenge again. What do we do? Do we save the tooth or do we not? That's exactly what we have felt with this case. It's an all-on-6 case. Now, if you have a look, heavily restored dentition, smile line is reasonably favorable. There's perio there, unerupted canine, caries, the anterior bridge is connected to 5 units and it doesn't fit. What do we do? You know, there's years of continuous treatment. That's what they're facing. Perio recalls, endodontic treatment. And what does the patient actually want? We've got to weigh this up as well. But also making sure that the patient isn't making a mistake and we're the cause of that mistake. So we actually decided to go for an all-on-6, and he wanted something a little bit different, a little bit more lifelike than an acrylic bridge. So thankfully, the smile line was perfect. We went for this metal framework. Obviously, that's not his final look. He's not auditioning for Martin James Bond, but we went for one of these bridges with individual porcelain crowns, which is highly retrievable, because if anything broke, then we just replace a single crown. So they were prepped by the lab, or the metal titanium framework was designed that way, milled that way, and then individual crowns placed with Gradia, composite Gradia pink. And that's how he looked with the smile and with the cheek retractors. Cleansability, ideal, because we can get in there. We made flossing channels, and you see on a very, we try and get these patients on a very strict recall regime of initially 3 monthly, and then maybe move it up to 6 monthly. For our full arch immediate loaded bridges, we like to, if we can, if they're amenable to it, take the bridges off once a year and clean around the implants and replace them. So we have one more case to show you, another couple of cases actually, with the upper left canine, what we do in this situation. Now, this is a teacher, and I put down teacher because unfortunately it was my kid's tutor. The occlusion was compromised. There was a lot of wear, fractured crown, difficult to visualize. And do we insist on a full mouth approach? And I'll show you why. This is the canine root, lateral area, fractured post, which wouldn't be too difficult to get out. And there's enough dentine there, and that's his smile. If we go back, there is enough dentine there. And you look at the premolar just behind, there's issues with the fit of that. There's already a post or pin in there, a poor root treatment. We've got a virgin tooth next door. So, should I be restoring that? That's one option. That's his smile. A lot of wear. That's the canine that's fractured. You can see palatally, there's a lot of wear as well. Again, a lot of, I think this is one of those cases where the crowns were adjusted at some stage to fit. Rough porcelain was left, wore down the lower anteriors due to grinding, and then you can see this roller coaster occlusal plane that he has. And there's obviously some evidence of grinding and clenching. So do you think, well, do we really want to be putting implants in someone like this? It's a highly hostile environment. Do we want to do anything in this situation? Or do we look at it and say, this person needs a full reconstruction? At the Eastman, we could do that. But in dental practice, patients might not be able to afford that sort of treatment. And they're not aware that they actually need this sort of treatment. It's our jobs to actually inform them and make them aware of what is and what can and can't be done. So I just thought, I'm not restoring this. I'm going to remove this tooth because I think I can get better predictability with an implant in that site, share the guidance elsewhere. That's the apical area that we removed. And the reason why I'm doing it this way is because I wanted to put an immediate implant in. I did not want to lose the bone or the papillae. I want to load it straight away, put a temporary crown on it immediately in this highly hostile environment. So remember, this guy is my kid's tutor. So effectively, I've got their future in my hands here because he'll be seeing them almost every day at school. But he also, school's a rough place, as we all know, and they are ruthless. So I needed to make him look good and function well. And the only way I could do that was with an implant in my mind, because I couldn't give him a denture. I couldn't bridge the adjacent teeth. I couldn't even put a temporary bridge in there. I needed to put an immediately loaded implant. So there's my implants in place, temporary ready. My temporary acts as a guide as well for my implant placement. I finish it off with composite, make sure the guidance is, the occlusion is right and the guidance is better, so it's off the adjacent teeth, and then fill it with PTFE and Memicil. And he lived like that for a little while. But I take this photo because I always forget to mention, in this case, I always make him a protective guard to wear. So that's him with his temporary in place on the day of surgery. And thankfully, he could go back to school and function well. And my kids got good grades and everyone was happy, thank goodness. And just checking the occlusion to make sure he's safe. He's guiding on that lateral, which is great. This is my polishing kit to make it smooth as possible. That's the final restoration, which is screw retained. And that's when he came in. That's how, what the crown was out. That's me doing an implant midway, making sure that it's in the right position, missing the sinus and the front of the nose, and that's the implant in place. And that's the final crown that's been functioning for many years now, because my kids have now left school. So, and they're still there. So I just needed it to last until they left school, and it has done more than that. So everyone's happy, thank goodness. So we have to think about long-term protection, the longevity of restorations and dentition protection. And always give a stabilization, a Michigan hard occlusal, upper hard occlusal acrylic splint. And I don't give them the option, I actually put it down as a treatment plan. This is a cost option, not like how they sell cars with a no cost option. This is a cost, not even a cost option. This goes on the treatment plan and they get it at the end of treatment. That is part of their treatment, not an added extra. So really, we're educating people for treatment planning. They're unwilling to look and treat the whole dentition because of time, cost, or worry, but we can split that up. We can make them aware of it, really. We can manage segments at a time and make things more palatable for people. We treat and retain the good teeth. I'm not saying remove all teeth no matter what and give them their final set of implant retained teeth. Keep good ones, of course. Remove hopeless ones and try and simplify the treatment plan. with implants, like this sort of case where 2 premolars, where someone's had a chance to think, well, I could maybe save them, but no, they couldn't, and they went anyway. So how much did it cost to go through all of that to finally put implants in, and how much bone loss did we lose in the meantime? There's an element, there's an argument to say, should you be just placing the implants straight away and retaining as much bone as you can? So we've got to think about careful planning and execution, not like this, where it looks like someone's just taken a bunch of implants and threw them at the maxilla and hope one works. And actually one did work in the middle there. But, you know, when you are proud of your hammer, like me and my implant hammer, everything looks like a nail. That's one of my favorite sayings. You've got to keep an open mind, really, have a more balanced view of your dentition and what to do. Things can still go wrong, but a lot of them is not the fault of the implant. It's the fault of the dentist or the surgeon or the person who's doing it. So how do we view dentition? I think life expectancy is increasing. Should we be educating patients in the life expectancy of our work? I mean, I'm the first to say our work is not going to last forever. We'd love it to, of course we would, but it isn't. They need to be educated in that as well. It doesn't mean that you tell them that your work's rubbish, but you do need to tell them that there's wear and tear. The mouth is a hostile environment. It will need repeated replacements, continual treatment. And you've got to think of what's acceptable. What is acceptable? You know, I view it this way: primary dentition, deciduous; secondary dentition, their permanent dentition. And do we move on to the tertiary dentition, which should be their implant dentition? Is that the right thing to do or not? Now, I think in treatment planning, if there's 90 to 95% chance of any prosthesis in our patients surviving 10 to 15 years, that's more than acceptable, actually. I'm saying to patients now, it's acceptable to look at replacing your restoration anywhere after 8 to 10 years. Now, that doesn't mean it's guaranteed for that long, but I'm saying that's how long it should last. We have to educate the patients moving on from one type of tooth replacement to another, and the validity of retreatment. It's actually okay to retreat teeth and retreat them. Things do break and wear down. It's just a mind shift. It's a shift in their way of thinking. And there's no such thing as permanent treatment. Now, I had the massive honor of actually presenting the part of this lecture to Peter Briggs, who actually trained me when I was a young boy, and he was a brilliant dentist. And they did a paper about options for tooth that require root canal treatments and the years of follow-up. So implant success rates, fixed partial denture success rates, or root fill teeth. And we can see that as time goes on, the implant success rates and survival are very, very good compared to the others that are slightly going down, except the root filled ones in one aspect, which are quite good. So really, the conclusion from that paper was, is it better to spend available resources to maintain natural tooth for as long as possible? It is, I think it is, as long as you can ensure that it's worthwhile doing so and it doesn't fail or make your permanent final restoration compromised in any way. However, we mustn't forget that the whole point of this was the fact that implants are extremely successful. The most successful success rates in dentistry as we know it, really, when they're done right. Now, what I'd like to also leave you, actually coming to the end of this lecture, with just a reminder of what we try and achieve every day. And one phrase that I thought was quite funny is that about education, really, is that the more that you read, the more things that you'll know. And the more that you learn, the more places you'll go. Now, that was by an eminent philosopher, Dr. Seuss. So thank you very much. Thank you, Mish, and thank you, Gentle Dental Care, for asking me to speak. I hope I haven't sent people to sleep on this very dreary afternoon in Cambridge. I hope it's sunny elsewhere. Thank you, Mish. I think we sent Mish to sleep as well.
No, I'm here. I'm working out which buttons to press.
Sorry, Mish. Am I?
That was really good. It was really good.
Oh, here.
Well, you happy to go through a few questions?
Do I need the slides up again?
Not particularly. I think it's just yourself and
Sure.
Anybody that wants to ask any questions of Wail, feel free to shoot them into the Q&A. I'm just going to start off with a few little things that I'm interested in. So, Wail, just some simple questions. I mean, you're moving. You showed some Straumann implants, bone level. Didn't see any tissue level, I don't think, in there, and you now use Nobel as well. Any particular reasons for choosing moving and your decisions over time?
I'm from the old school where originally when Straumann tissue level was out, they didn't have bone level. There was tissue level, and at the time, with tissue level, the whole purpose of using them was to always graft with them. They were using the anterior zone; they were always grafting. And where I was trained and brought up, it was bone level all the time. So I was naturally that way inclined. So when Straumann came out with the bone level implants, it was a natural progression. It was fine. Now, in the practice, we actually have Nobel and Nobel sponsored courses. We've got Straumann courses and use Straumann as well, Neos and Dentsply, because we've got quite a few practitioners, and we are, we have referrals, and a lot of practices are starting to restore, so they ask for a specific implant type. So we don't want to limit ourselves to one type of implant. And it's also very nice to have a lot of other expertise in using other implant systems, because it widens your knowledge really. But personally, I've got no favorite. I generally tend to use the implant per case. So for sinus lifting, I'll want a blunt-ended implant. So the bone level is fine, the tissue level is fine. I wouldn't use a Nobel Active or a BLX that are end cutting, because they're just a bit too aggressive. For the anterior immediate loaded cases, yeah, definitely BLX or a Nobel Active because of high torque. For immediate loading, I'll do the same. The Neos implants are lovely. I love the surface of Neos implant. I usually put them for, again, for sinus lifting or posterior implants, because they have this graded bimodal sort of surface that gets smoother as it goes up. Even though it looks the same, it's actually a lot smoother coronally. So if it's ever exposed, and they can be exposed in the coronal aspect, cleaning's lovely. So I like that sort of aspect as well. So there's lots of different designs. I don't think there's one system that's perfect, and I certainly wouldn't be saying to everyone, you must use this.
Well, my only kind of question is that we've had a lot of kind of implant systems that we've trialed, gone through the process with, and it's just keeping all that kit, around, and making sure that the nurses and the rest of the team are kind of au fait with all that, because I have a box of something kit, where certain things sit, and then there's another kit, and then there's a box of question mark stuff that people don't know exactly where it comes from, because we've trialed things like Anthrogea and Neoden and pretty much everything under the sun when we've had that. So that was just one of the questions that
can I ask you, you've got fantastic practices, and you've got multiple practices. Do you ever have, and this is a question out to everyone really of big practices, do you have a screw amnesty day where people can just come along, dump everything, hands up and walk away and say, right, let's get it all sorted again? Because we need to do that as well.
There certainly is, and at the end of the day, we there is a lot to be said. I'm really happy and glad that you spoke about kind of ownership as well. It's their implant, and we need to help them with it. And if they have problems with it 5 years down the line, it's a kind of co-management, co-treatment, of those cases. If there is an ownership associated with that. I've had patients that have, diabetic that I treat slightly differently potentially to patients that aren't, so there are always kind of, you look at these things as well, and from training and understanding that their biology may be a bit different, you let things heal a little longer as well. So absolutely. I'm gonna rather than crack on with some of the questions that I wanted to ask, we've got some from the rest of the audience, so let me look at asking and answering those. So What's your opinion on implants from small manufacturers? Umair asks.
What they're actually asking in that.
You know,
That's quite a big question.
I guess the I guess that there is this concept, whether you buy into it or not, is there are the big companies, and to a certain extent I do, Dentsply, Straumann's, Nobel, to name just a few of the kind of quote unquote top tier companies, and then there'll be some of the other smaller companies, or not, he says not the big six. What about like Champion Implants and others? I mean, don't want to name names, but smaller implant companies. How do you feel about those?
Do you know what? I think it's all about how the implants are manufactured and packaged. Now, I attended a Southern Implants World Symposium in South Africa once, and a chap presented a paper, and I'm sure you must have heard or seen it, where he bought implants from many companies and just put them under a scanning electron microscope and had a look at the implant surface and found various things on their surfaces that shouldn't really be there. And you got to think, well, cheaper implants are cheap for a reason. There's got to be, you have to make a saving somewhere. So I just feel that with myself, I don't want to belittle a smaller implant company, because everyone needs to be given a chance. But you've got to just question the manufacturing, the cleaning, and the packaging of it, and how it gets to you. But also you've got to look at the support, how long they're going to be there, and what happens in a few years, and how quickly they're changing their designs as well. Because for some reason, and I still don't get it, I've got to be honest, is that people just seem that they need change, and with every change comes a new kit and a new screwdriver and a new cost. And what was actually wrong with what we had? I can understand
the new Astra system, where they went EV, and there's quite a big hullabaloo about why they needed that change, and there's certain reasons for it, but it feels like, especially when you take something off the market, it's difficult, isn't it?
Well, you've like for Neos, they had a perfectly wonderful system, which is the straight Neos implants, right? Then they brought out the tapered one. I mean, it still works. It's beautiful. It works fine. I can see it. Now they brought out the Edge, and I was lucky enough to be one of the 3 testers for the Edge implants. We did a case report on it to see how it worked for immediate loading, and that worked fine. It's still got the same surface. It's beautiful. It works well. There's some bits about it that I don't like, but as part of my feedback, I said, well, it personally doesn't give me any more than the original implant did. So if I was coming into that system without having known anything, then I'll probably use it. But there was an evolution. But for me personally, I was getting the equal results with the straight proactive implant that they had originally. It was highly retentive. It had massive primary stability, as everything you wanted.
My good friend Ian is asking, Ian Gordon, he said that there's an excellent presentation.
Oh, thank you.
Where do you think the next big revolution is, and do you see an increase in the use of digital treatment?
That's already with us, I've got to say. It's the only thing I didn't really put in here because I didn't think it was place for it. But yeah, we're fully digitized when it comes to implant planning. You saw a little bit of Simplant, so we're doing all of that as well. We haven't done so as much, but we can print our own guides. Everything's being scanned now. I can't remember the last impression I've taken with silicon. So yeah, it is definitely there. And with a lot of people getting into smile design and I personally don't do orthodontics, but with Invisalign and all that sort of thing, it's here, and it's here to stay, really. And the accuracy for my own restorative work, my crown and bridge, my bread and butter crown and bridge, beautiful dentistry. It's wonderful to be able to magnify things and high definition scan the margins. I tell you what, Mitch, it makes me better at what I do, because I can see my result in front of me.
Wail, I guess you place your own implants and restore them. Is that right? So I'm in the somewhat different position, because I historically did that, but I have a prosthodontist with me, so I'm in a position where I'm predominantly doing the surgeries and so on. So I'm not doing as much of that. But he does not. I could count on one hand how many implants in a year that he restores. With silicone, impressions. It's all digital and scan flags and so on as well.
Yeah.
So, and the accuracy of it is, just second to none. So that's what we're finding.
One thing that's lovely is with all of the implant companies have scan pegs now, so that's lovely. One thing that have been very impressed with is the Neos aesthetic abutment, where it's a anatomically formed abutment that you put on the implant, and you never take it off. So you put a scan peg into it and scan that. So the only time that abutment comes off and that gingival cuff is broken is at time of placement of the final restoration, which has been quite nice because it already forms your tissue. And there are other standalone companies that do that sort of thing for various implant companies. But that's been a nice thing. But all of them have these scan bodies that work. And yeah, I'm the same. I scan everything now.
I remember when Zimmer, and when I used to use them, I was one of the first people to use T3 implant for 3i and Biomet Zimmer. And, that was one where the healing abutment, you could actually scan or take a version of that, and they could work out from there. That's
quite clever. I remember that actually, yeah.
So that was quite cool.
Never lucky enough to use it.
What's that?
Never lucky enough to use that system. But
you know what? It wasn't. I didn't use it all that much, but I moved on quite quickly on from there for other reasons. Another question coming in here is, which implant system do you favour for all-on-4 and kind of full arch work?
I have done them with Straumann, Nobel, and Neos. The reason why I've done it with various ones is because when they're referred in, the dentists are used to a certain system. But if I had my choice, I would use an implant that again is quite, I don't like using the word, but it is aggressive, which means it gives me very high torque. It has bony compression as well. So BLX, Nobel Active, that sort of thing. We used to use, when we first started all-on-4s or full arch immediate load, we used to use the Nobel Speedy Groovy about 8 years ago. 10 years ago, my God. I just didn't like it. Personally, didn't like it. I like the Nobel Active and BLX. I like that reverse taper at the top, which doesn't put any bony compression on the area where the bone is thinnest, where you need it the most. So I quite like that sort of aspect as well. A lot of the compression is 3 millimeters down, and on photoelastic studies, you can tell that's where a lot of the pressure is on the teeth. So anything like that, those sort of implants, Nobel Active or BLX, is quite cool. I like that.
Do you use any of these? Another question that you kind of alluded to in one of your cases is partial extraction therapies, in terms of just leaving a bit of tooth behind buccally. Do you do much of that?
No, not at all. And the only reason is because I'm actually waiting for Hertzler's 10-year studies on that, because I went to Boston, and if there's ever a place people want to go to for an amazing lecture when the world goes back to normal, for lecture series, every 3 years, the Quintessence meetings in Boston, brilliant. And he presented there 2 years ago. And people were trying to, in the audience, there was a question panel about partial extraction therapy and asking how much root do you leave exposed above the crest, and he wouldn't actually answer, and people kept pressing and pressing and pressing, and he said it was great at the end, and he said, do you know what, it all comes down to my gut feeling on the day. And we thought, well, we need more than that. So he said, just wait for my papers on that. 3 years before that, so 6 years ago, they were saying don't do it. They weren't getting good results, but now that's why the Quintessence meetings are quite good, because they're 3 years and people have changed in their 3 years. They've studied, they've got some decent results, and they're showing things. So no, I just feel in my hands it might not be predictable. And also, we are all in private practices with very demanding patients. I can't use them as guinea pigs. There's no way.
I accept that, yeah. Do you use anything like PRGF or PRP in practice as well?
Yeah, we definitely do. Yeah, we've got PRF. We got both actually. I use PRF a lot of the time, certainly for full arch cases or big cases. I put that everywhere, even in immediate placement, immediate load anteriorly, I'll still lift a little flap and place, whether it be allograft or xenograft, and PRF as well. And I put that everywhere. And for the full arch cases, the whole jaw gets it covered completely.
And what I mean, in your experience, what is the difference in terms of how does that make a difference to your potentially healing patient kind of outcomes? What are the differences that you find with that?
I think well, PRF for a start, I do find the healing is better. The results around, I'm not saying it will give me more bone. I'm not saying that at all. I don't think they say that either. With PGRF, yes, you will probably get bone, but PRF, I think it's more of the healing. So
You mean the initial healing, or
yes, yeah, initial healing post surgery, and also if there is, if the flap isn't fully closed, I like to have that over that area. So it just gives me, so I don't have to force the flap closed. They shouldn't do that anyway. Non-tension suturing is the way to go. But yeah, I use that a lot in every case. Okay, and also for sinus lifting as well. I just find it heals far better that way.
And in sinus lifts, do you use it as? I guess you place the bone graft material in, and then place a membrane over the top. Are you still placing like that BioOS over the top, or are you just using PRF or PRGF?
No, I'm using some xenograft as well, BioOS, but also we've got using it in certain cases. We use a little bit of ethos when it's not massively pneumatized. If there's decent bone, then I'll use some ethos. Some patients request it; they don't want any animal or human. Using some Mineros as well from BioHorizons. That's lovely. I used a block last week to build up anterior. That's beautiful stuff. So it makes surgery a lot better for the patients. So you don't have to take bone from somewhere else in their body and put it. There's or human femur bone block that you can put and shape into the right place. That's really nice. There's Nova Matrix I'm starting to use, which is the replacement of soft tissue grafts as well. So there's a lot of these materials coming through. So it's a huge amount. So it's a case of just being educated, picking what you need for a specific site.
My question was more related to, the window that you kind of have a Macron unit, you open that sinus. Do you still use the Macron, or do you use something different? Yeah. And then you find the window. Are you still covering your bone graft material with a membrane, or are you going to use PRGF?
No, still use a membrane.
And then over the top of that, some.
Yeah.
Okay, fine. Okay.
Yeah, totally. So I usually put bone into the sinus, implants, and then a more allograft or autograft in there, and then xenograft, then membrane, then PRF.
Okay, so a proper sandwich.
We're always hungry, Fish. Always hungry.
There you go. And what do you think? What are your thoughts on in terms of, let's say that there is a healed ridge? How long are you typically leaving your implants in the maxilla versus the mandible, and in terms of times? In terms
of what, a full arch?
No, single units or bridges. And
some of them anterior. Sometimes I just load them immediately, depending on if I can get a decent over 60, 70 Newton centimeters of torque. But otherwise, depending on the grafting, if it's majority of in bone, I'm cosmetically grafting, not functionally grafting. Then 3 months and I'm in there. I usually put a healing abutment on straight away, or an anatomically designed healing abutment. Unless there is a lot of deficiency, then I'm thinking about doing a second stage, but generally 3 months minimum. If there's an awful lot of grafting, then 6 months or more, and depending on the type of grafting that we use, whether it's allograft or xenograft.
Yeah, fine. No, I was kind of more curious in terms of loading protocol, given different surface design and aggressive thread and so on. I historically was doing 4 to 6 months, and now I'm down to 2 to 3 months, just because our implant designs are allowing us to more and more. So I think with me, I either load immediately or I wait 3 months. It's less in between kind of.
Absolutely. Because I think if I'm leaving it 3 months, that means there's something not right. I'm too nervous. I'll leave it.
Fair enough. Let's see, there's another question here, which is as an implant dentist, placing in the aesthetic zone or the anterior zone, would you normally prefer to extract the non-savable tooth yourself to preserve the anatomy than the referring dentist?
100%, 100%. Because if I create a problem, I can deal with it there and then.
Yeah.
And what I don't want is to take, unless I know the person, and I work in one practice where I help out in Oxted, and one of the partners there, we did MaxFax together.
Mm-hmm.
So I know how he does his teeth, and so I don't mind him taking teeth out because he knows exactly, understands what I need.
Yeah.
But generally, unless you build up that working relationship, and the last thing I want is a site that I need to graft before I even look at an implant. And generally, I say to referring dentists, if anything's fractured 5 to 5 anteriorly, or it needs an implant, take a CBCT or order one for me, because I'll more often than not do an immediate implant.
Mm-hmm. So would you say that in the 5 to 5, you're doing a high percentage of your cases as immediate?
To be honest with you, Mish, almost 100% now. I've got to be honest, yeah. Unless there's an issue with it, then generally, yeah. And those issues can be sinus in place or not enough bone there, not enough apical bone, no stability. But generally, yeah, I'll do immediates.
Yeah. And in terms of just coming, because we're talking about immediates, how do you feel about the management of kind of soft and hard tissue, given that let's say a premolar where you've got 2 roots and you're either placing into a root and then managing the soft tissue deficiency, because that or the deficiency in terms of getting primary closure. How do you feel about getting it right in terms of immediates?
Well, in that situation, we're putting a bigger healing abutment on for a start.
Yeah.
So that will take up a lot of the space.
Mm-hmm.
Then we've got various methods of trying to get closure without pulling the flap over. We've mentioned already PRF. We've
Mm-hmm.
mentioned Nova Matrix as well. We've got lots of other materials that we can use as a tenting membrane on that. So there's methods of doing that without pulling. But a lot of the time, I'm actually just lift the flap, to be honest with you, and advance it that way.
Mm-hmm. Yeah, undercutting it or just making it wide, or what are your kind of thoughts on that?
It's the basic terms of periosteal release, just to allow that flexibility, and then I can generally close. And I always use extremely thin sutures because there's a tendency to be heavy-handed. So if I'm using a 4-0 or 5-0, then I can close it by putting tension. If I'm using 6 or 7-0, it will snap.
Yeah.
So it's my fail-safe. So I'll use the 6 or 7-0 and I'll get closure without being completely under tension.
Yeah, cool. And let's just see if there's any other kind of questions here, because those are just some of the questions that kind of came in.
Can I just say hello? I just noticed hello to Alochana Naniakara, who's our consultant. We trained together. We shared a job, and one of the most talented and loveliest people on this earth. So hi, Loach. Lovely to see you again. I miss her.
I was involved in some of my training at the Eastman as well, so a great shout out to her as well.
Absolutely.
Rav there as well, that's just said that he's caught the tail end, but
Rav.
Great content as usual.
Oh, what a sweet man. That's very sweet.
A couple of other questions. In terms of CBCT, are you pretty much routinely using it for every case now, or would you say that there? Yeah,
100%. Yeah, I don't see how I look back at we've been doing implants for 25 years, and the original cases we used to send away for CBCT scans, and they came back with those big sheets, and with and you'd have to work it out. And a lot of them, to be honest with you, Mish, I'm just amazed that we didn't run into more trouble.
Yeah, that's what I say when I'm going through these things. It's just like we got away with it.
Absolutely, 100%. Because we used to plan cases, sinus lifts even on a bite wing or a PA.
Yeah.
And I think back, what the hell was I doing? This is insane.
Crazy stuff, isn't it?
Every case, CBCT, every case.
Yeah, and in terms of the use of guided, are you doing much guided surgery?
All of our full arch cases are guided, whether it be a pilot drill or not. We, in certain cases, yeah, we will guide. It's not every case. I'm going to be brutally honest, not really. Not every case. There are some cases that I just think it makes me feel nervous. I need to go guided for perfect positioning. In which case, yeah. And again, we generally use in our practice Implant, because we bought that software 100 years ago, that we know how it works, and it's open now, so we can design it on Implant, extract all the information, send it to our lab, who can print us out a guide ourselves. So we've got it all on site. Anyone can do that for our lab. It doesn't really matter. We just print them for anyone. But it's a definitely way to go. I don't agree with teaching people guided surgery to begin with, because by doing that, flapless or guided surgery, I think they lose or they de-skill. Because what happens if it goes wrong? You've got to be able to.
I had like a couple of weeks ago. The guide was totally wrong, and you could. I have these windows cut into the guide so that you can see whether it's seating fully or not.
Yeah.
And it wasn't there until I pushed it down, and trying to hold it in place and getting it accurate. I had to just go freehand, but you had to be able to have the confidence to do that, because otherwise, you're stuffed if you're just going to follow this guide through.
Totally. You've got a great mate of mine, Leon Parente from Paris. Leon says it's guided surgery, not blinded surgery. And absolutely right. People with guides tend to be blind and just rely on the guide. You don't know where you're going, so you need to be able to correct it. So you've got to be taught proper surgery first. Yeah,
absolutely. If there are any other questions, please feel free to ask. Wail, I think we're pretty much there in terms of time as well.
Sure.
I'd like to just thank you as a kind of final comment on an excellent presentation. Really lovely kind of indications of how you've gone through, your history to a certain extent of how things are. Lovely evidence base as well. Everything was understood and quoted and so on. So thank you so much for an amazing presentation.
Absolute honor.
We'll welcome you back soon for some other kind of talk as well. So that would be really, really good.
Mate, I think like some of the great teams, we're a sum of our parts, and definitely one of my parts is your dad. I tell you, he's made a big impact on me. So I'm only here because of him, to be honest with you. So thank you.
And he thanks you for a wonderful presentation. He's just
my man.
There as well. He's been watching through this thing and said some very lovely.
Thank you. Oh, it's lovely. It's a great honor. Thank you all.
For our attendees, there's a link in the chat for CPD for this event. So please go ahead and click on that. We are supported and sponsored by various companies, including the CUR, we're sponsored by Tony Knight and Denplan as well. So if you can tick some boxes to say that you might want to hear something more from them, that would be great. Next time we're talking, I think we've got David Bloom talking about some anterior aesthetics, so that should be good. And we'll crack on for the next series part of our webinar. But another final thank you to Wail for giving up his afternoon and probably a lot more than that for putting this presentation together as well. But it was really, really inspirational, and it really shows what can be done. Thank you.
That's very kind of you. Thank you very much.
So, Wail, I'll catch up with you probably relatively soon, and we'll catch up soon when as everything's opened up. But it leaves me to just thank you again, and we'll catch up next time in the seminar program. Any issues in terms of getting CPD, please contact James, and he'll sort that out for the delegates there as well. So have a great evening, and thank you again.
You too. Thank you. Bye, guys.
Bye-bye.